All right, good morning, everyone. Welcome to the Regional Clinical Rounds. Today's speaker, you might recognize him because his photo is on the wall outside. It's well-deserved. Professor James McKillop, he's a clinical psychologist. He trained in Rhode Island and New York, eventually joined the faculty at McMaster in 2014. He's an expert in addiction medicine in particular. With initially a clinical psychology practice, but then an ever-growing research career with over 400 publications in the field of addiction, with a particular focus on nicotine, and then more recently research in cannabis as well. He's involved in behavioral economics, which is a fantastic way of looking at the holistic sort of reasons that people become addicted to substances and how to help people to overcome those addictions. And he's going to speak to us today about clinical and research opportunities at the intersection of substance use and lung health. It's going to be a fantastic talk. Everybody, please enjoy.
Thank you, Marcel. It's great to be with everyone today. It's obviously a great honor to have your picture at Charlton, but it's also a little bit like the picture of Dorian Gray. I keep getting older and the picture doesn't age. It's when I first came to St. Joe's nearly 11 years ago. So I appreciate it, but it's a little comical in some ways. So today I'm going to kind of give you a smorgasbord of work we've been doing at the intersection of substance use and substance use disorders and lung health. And full disclosure, this is a form of evangelizing. I want to do more of this work. I think there's a really high priority, and I think that hopefully some of the projects that are happening and initiatives that are happening will be able to grow, and I'd love for people in this room to be a part of this work. In terms of just disclosures, before I get started, I do receive unrestricted federal funding and grant funding from various agencies and philanthropic initiatives. I am a co-founder of a technology transfer startup company in the US that does not have any relevance to today's talk. I don't have any relationship to any cannabis companies. I don't own any stock. I don't have any kind of or receive any kind of funding. I do direct two research centers at McMaster, the Peterborough Center for Addictions Research and the DeGroote Center for Medicinal Cannabis Research. And one of the questions people often have is that funded by industry? It's not funded by industry. There are some selected industry partnerships, but our central operating funding does come from a philanthropic gift. I also want to start by acknowledging a lot of folks who are very actively contributing to the work that I'm going to present today. Jay Hirota and myself have been collaborating for a number of years on this area of intersection, and more recently, Terence Ho and Imran Satya have become part of this work. Jay's postdoc, Nadia, has been an important vector for moving some of our data forward, and a junior faculty member in the Peterborough Center for Addictions Research, Dr. Sabrina Sayan, is an addiction psychologist who's also focusing more and more on tobacco use disorder. And then we have some really amazing staff at the Peterborough Center who've been the boots on the ground, really moving this work forward. Leah Rahman and Desmond Singh are our project coordinator and programmer, respectively, who really create the connective tissue and the electronic and human infrastructure to make this work. And Kyla Belizario is our biostatistician par excellence, who does a lot of the data analysis and visualization that I'll show today. So just to sort of give you an overview, I'm going to start out with what I think will be a foregone conclusion for a lot of people in this room, that there's a strong epidemiological case to be made for why we should look at the intersection of substance use and lung health. I hope you won't say thank you, Captain Obvious, and tune out during this period, but I do think it's important to set the stage. And then I'm going to tell you a bit about some of our current research initiatives where we're actively collecting data and interrogating this intersection, and also then talk about a clinical initiative that has been rolling out at St. Joe's in the mental health and addiction program called measurement-based care. And that has also been happening in the Firestone Institute in collaboration with Terence Ho. And so I want to give you a sense for what that could look like if it were expanded more broadly or implemented differently in the next iteration. And then the last piece will be on our neuromodulation initiative at the Peterborough Center for Addictions Research, which is a powerful new strategy for treating mental health conditions and I think shows a lot of promise for tobacco use disorder and cannabis use disorder, and could be a novel strategy for patients with lung disease who are treatment refractory and have not responded to the standards of care for tobacco use disorder. So lots to talk about. I'm going to keep this pretty high level. I'm happy to answer any questions during the question and answer. This is going to be more forest than trees, but by all means, do ask any questions that you have. Just to give you a bit of background, so my lab has 4 pillars. I do what I broadly refer to as translational research on addictions. And so what I try to do is connect the dots from more basic research to clinical and applied foci. So I'm a psychologist by background. I'm very interested in the psychology of addiction. I'm interested in decision-making. That's where behavioral economics and neuroeconomics comes into it. So at the heart of all of my work is a focus on human psychology and behavioral science. But what we try to do is then unpack that to understand the neural underpinnings of addiction by using either structural or functional MRI, and more recently EEG, to understand where addiction lives in the brain and what aspects of the brain are responsible for maladaptive decision making. And then we try to forward translate some of the insights from behavioral science to answer clinical questions, to identify the next generation of diagnostic tools, interventions, and to answer questions in public policy. And across each of these different domains, we look at how genetic variation contributes to variation in behavioral phenotypes, in imaging phenotypes, and clinical outcomes, both because we know that genetics plays an important role in the development of addiction, but also we don't know the mechanisms by which genetics plays a role, and these different phenotypes, behavioral, clinical, and imaging, may afford insights into that. Now, today, I'm mostly going to talk about 2 domains, behavioral science and clinical research, but hopefully this framework provides some context for some of the different directions that we're pursuing. Okay, so to start in terms of why this intersection, for me, there's always been a natural Venn diagram. I study addiction and medical cannabis, and what we know is that especially for tobacco and cannabis, but other substances too, the lung is the most common route of administration. So to me, it's always seemed like there is a natural overlap between addiction research, cannabis research, and respiratory disease. So this is sort of the basic context. But we know more than that, obviously, from epidemiology. Fundamentally, we know that tobacco use is a major upstream cause of lung disease. We also know that successful smoking cessation is one of the most robust interventions for lung disease. And I was sort of faintly aware of this before I came to Mac and started to get more interested in this intersection, but it really came across in stark terms when I started reviewing the literature. And I was digging up some of the articles that I looked at early in this area of interest. And this was a review on smoking cessation and COPD. It's now a few years old, but I think a lot of the conclusions hold. And fundamentally, the take-home message was that smoking cessation is the most effective intervention in stopping the progression of COPD, as well as increasing survival and reducing morbidity. And the deeper I dug, the more it seemed like the COPD is obviously only one lung disease, but a very challenging one. And it seemed like the evidence was that the only way to really arrest progression was in smokers with COPD to stop smoking. And so the fact that the conclusion in this review is that smoking cessation should be the top priority in treating COPD really sort of struck me as a clinical psychologist. And to provide a little bit more context, before I came to Mac, I actually ran a smoking cessation clinic at the University of Georgia. That was the program that I used to train the clinical psychologist in my lab to provide evidence-based care. So this to me was a sort of underlining that this is a really important thing to be thinking about in terms of lung disease. And then the other thing that really came onto my radar was that for a long time, we knew a lot less about cannabis and respiratory illness, but we now have a much more robust evidence base. And unfortunately, as the rates of cannabis use have gone up over time, but we also know that there is substantial morbidity associated with cannabis use and lung health. So This is an overview from a recent systematic review of what we know about cannabis use in lung disease. On the far left, you can see the various conditions that were synthesized in this review. Where you see, and then on the far right, you can see the quality of the evidence. The red, yellow, green traffic lights convention basically shows where the morbidity is. And so you can see that there are a number of conditions that have been fairly robustly implicated with being at least exacerbated by cannabis use. So, for example, I'll highlight asthma control and lung cancer, which now have quite robust evidence implicating cannabis in terms of those outcomes. The evidence is weaker when it comes to bronchial respiratory symptoms and bullous lung disease. Specifically, pneumothorax seems to have slightly stronger evidence, but even though it's not the case that cannabis smoke seems to be as toxic as tobacco smoke, there's nonetheless quite robust evidence that it is also associated with harms when it comes to lung health. And then my own interest in this was really cultivated clinically by virtue of our patient populations in the mental health and addiction program at St. Joe's West Fifth. And no doubt, if you've been to West Fifth, you see that many patients, even though it's prohibited, are smoking outside. We struggle a great deal with managing that issue, but also tobacco use disorder in general in mental health. We know that people with mental health conditions, especially substance use disorders, are at radically higher risk for lung disease. These are the upstream conditions that lead to chronic lung disease. We know that these individuals smoke more often. Among smokers, they smoke more cigarettes per day. In terms of cigarettes per day, they also have a higher smoking topography, meaning they take more puffs, they inhale more deeply. They are essentially they are essentially at an exponentially higher level of exposure, and they're therefore at higher risk. So mental health patients, we know, have a much higher morbidity and mortality from respiratory disease. And we also know that, unfortunately, this population is less likely to respond to our standards of care in terms of smoking cessation. Smoking cessation is not easy to do, but it is very much achievable. But the unfortunate reality is patients with schizophrenia and other psychotic disorders, patients with major depressive disorder, patients with other substance use disorder beyond tobacco use disorder are much less likely to be able to respond to our best available treatments. They tend to be more treatment refractory. So that's really the context for why this is a very high priority for both the Peterborough Center for Addictions Research and the DeGroote Center. And so let me tell you about some of the work that we're doing now that is taking on some of these questions. And so the first study I'd like to share with you is an ongoing observational cohort study that was created with the prospect of cannabis legalization. Going back to around 2016, the Peterborough Center for Addictions Research created a research registry of individuals who would be interested in being in research studies of a bit over 2,000 individuals from the Hamilton community. And when we learned that cannabis was going to be legalized, we created a surveillance cohort inviting anyone from that registry to participate in the month before legalization, to then follow them every 6 months to see how legalization had various effects. So this is a visualization of the study to date. This is just through time 15, the 15th wave of data collection. We've been collecting data funded by originally by the DeGroote Center, most recently by CIHR, to basically monitor what the impacts of cannabis legalization have been. The line that you see on the y-axis is the expansion of the legal market. That's millions of dollars of cannabis per month sold nationally. So that started at $50 million per month in October 2018. It's now around $450 million per month in legal retail sales. So you can see a gradually expanding gradually expanding legal market. And every month, every 6 months, we do these assessments of around 1,500 individuals who do an online survey of their cannabis use, their cannabis attitudes, their tobacco use, their alcohol use, lots of different mental health behaviors. And we've been using this living time capsule to monitor what the effects of cannabis legalization have been. And I'd be happy to give another talk on what we found so far, because those have been fascinating results. But this cohort really offers an opportunity to learn a great deal about these people's behavioral habits in a lot of different domains and how those affect lung health. So just to give you an example, these are the alluvial plots of the patterns of cannabis and tobacco use over these 15 waves of data collection. We've been very fortunate to have around 85% retention wave after wave, in part because these were individuals who were already part of a research registry. So they were fairly research motivated. But what you can see is that there's a sizable proportion of individuals who are cannabis users. There's a sizable proportion who are cannabis and tobacco users. We actually have the smallest proportion of tobacco-only users, in part probably because we were recruiting originally from the Hamilton community, and many people at St. Joe's learned about the registry and joined early on. So it's a relatively low smoking group. But this gives you an example of the kinds of archival data sets that we can mine to look at behaviors over time. And so what we did exactly to that end was aggregate the data from, I think it was at this point, 13 waves of data collection to look at the total level of tobacco use, the total level of cannabis use, the overlap of cannabis and tobacco use, and look at that in relation to COVID-19 infection, and specifically whether people had any infection or two or more infections, multiple infections, at least according to self-report. And what we found was that when we parse the data very carefully, and this is a depiction of all the participants, each of these little blocks in this waffle plot is an individual participant. And this gives you a sense for the aggregated parsing of cannabis use, tobacco use, dual use of both of those inhaled products, or no use at all. When we parsed those different patterns, what we found, somewhat against our hypotheses, was that rather than tobacco use being a higher risk factor for COVID infection or repeat infection, it was actually dried cannabis use specifically that was associated with two or more infections, and after we parse the data further, any infection relative to tobacco use. Now, it turned out when we had these results that this was not the only study to find this. There is something referred to as the smoker's paradox in terms of COVID, suggesting that actually, although individuals with lung ill health are at much greater risk for morbidity and mortality, smoking alone turned out to be a lower risk factor than originally intended. But of course, in observational cohort studies, there are also all sorts of possible confounding variables. There were various levels of overlap in terms of patterns of use. So we view this as sort of a hypothesis generating study rather than a definitive finding. And what this has also allowed us to do is to kind of dovetail with CIHR funding to do much more experimental research to kind of get to the heart of the matter in terms of cannabis risk for lung issues. And what this has led to is creating a lung lab at West Fifth, very much trying to adopt the technologies that are used at the Firestone Institute to then be able to apply these approaches to understand the consequences of cannabis use, in particular, frequent or daily or more often cannabis use. So we now have a spirometry device, an oscillometry device, a pheno device. We already had expired carbon monoxide, and of course we have lots of patient-reported outcomes. But what we now have is a platform for doing much more precise, objective research to look at the consequences of cannabis use. And we're now about a third of the way through an experimental study called BBCAN, which is a case control study in which we can eliminate some of those potential confounding variables within PathCAN and look very precisely at individuals who use cannabis frequently. That is our cases, our daily cannabis users who use combustible dried flower at least daily and do not use tobacco and do not use e-cigarettes, and compare those results to control participants who are not anti-cannabis, who use cannabis periodically, because we don't want to have a supernormal control group. So these are individuals who occasionally use cannabis, also do not use tobacco, also do not use e-cigarettes, and are demographically matched in terms of age, sex, and income. And this will then allow us to hopefully have more precision in identifying cannabis risks. So What we're going to use are the lung assay, spirometry, oscillometry, FeNO, expired carbon monoxide, and our patient-reported outcomes. But we're also able to collect blood, so we're going to have a standard cytokine panel. We're actually measuring precisely in serum and urine the levels of THC and CBD, as well as their principal metabolites. We're doing both psychological and neuropsychological assessment, and also using dry EEG as a brain biomarker. So although we can kind of do big picture observational research within our existing cohort, this is an example of a study that will really allow us to get the most precise, most objective, most experimentally controlled data, still observational to the extent that we can't assign people to smoke cannabis or not smoke cannabis, but nonetheless will allow us to get much closer to understanding the specific level of burden and the mechanisms of burden when it comes to cannabis and lung health. And as I said, we're about a third of the way through recruitment, so hopefully in the future I can share some of the results from this study. So moving in the clinical direction, what I want to tell you about next is a project that's been happening in the mental health and addiction program for a long time now, well, for several years, focusing on measurement-based care for substance use disorders. And the work I showed you before was what I would consider kind of traditional behavioral or clinical research, or at the intersection of behavioral and clinical research in terms of recruiting participants from the community, getting REB approval a priori, really designing studies from the top down rather than the bottom up. And what measurement-based care for substance use disorders has really focused on is how do we kind of take the traditional research approach and turn it on its head a little bit. And so in particular, what we're trying to do is create a learning health system in which we use measurement-based care as our mechanism for supporting this learning health system. So a couple of definitions. Measurement-based care refers to the collection of standardized, validated, patient-reported outcomes systematically in standard routine practice. And a learning health system in this context is collecting data in routine practice that then is used to produce practice-based evidence that then informs the next generation of practice and creates a sort of virtuous cycle in which research is generated in real-world clinical settings with all of the complexity that is present, but informs real-world patients. And if we think about the kind of traditional pipeline of evidence that goes from a kind of top-down standpoint, from randomized controlled trials to clinical guidelines, this is the opposite direction in which we generate evidence in practice that then leads to practice-based evidence and leads to new insights. So the idea is that we don't start with eligibility criteria and who is eligible or ineligible. We start with who are we treating and how can we routinely collect data that can inform the nature of our patients and how to best intervene. So it's really a strategy for converting the real world into a living laboratory. Yeah.
Sorry, could you just go over that again?
Yeah.
Because it sounded good that they, want to do something different. But I didn't get the bit about how we see what we're doing now and then do something better in the future. Because unlike top-down research where you start with a research question and you finish up with an answer that says yes or no, that's effective. Where's the learning in looking at what we do, even if you do look at it in a systematic fashion?
That's a great question. And I hope that some of the data I show will answer it, but just big picture to start with, the nature of the learning health system is it's less about hypothesis testing and more about hypothesis generating. So for example, a randomized control trial might test whether a intervention A is better than placebo, let's say. From a learning health system standpoint, the question that you might ask is, what is the prevalence of certain comorbidities within our clinical milieu? Are there latent clusters of patients that have certain features together? Should we develop a care path that speaks to those individuals because we see certain regularities or patterns? So This is data I won't show, but I'll give you an example. We've implemented this system at Homewood Health in Guelph, which is a big mental health and addiction hospital. And in the first 1,000 patients who participated, we did latent profile analysis to see whether there were latent clusters of addiction and depression, PTSD, and anxiety. And we found that there were latent patterns that emerged. There were 4 of them, actually. 2 had high comorbidities, 2 were uncomplicated addiction. And then in the second 1,000 patients, we replicated that same latent structure. So that health system then said, we need to have a comorbidity stream because we see consistent evidence that there are about 40% of patients have addiction plus either anxiety, depression, or PTSD. And so that provided practice-based evidence to then say, we need to have a different program that focuses on those comorbidities. But that's the kind of top-down is more hypothesis testing, bottom-up is more hypothesis generating. And our rationale is that there's really room for both. These are complementary strategies, and too often we think about clinical settings as just the end point for where treatment is delivered, and not always the place where we can gather evidence. But hopefully there'll be some further examples. So let me tell you what this looks like sort of practically in our way of doing this. So part of the genesis for this initiative was that before I came to McMaster, as I said, I was running a smoking cessation clinic in the psychology department at the University of Georgia, where I was a professor. And my students were trained in treating addiction, treating tobacco use disorder and other addictions. But we would often bring tools down from the lab on the 3rd floor to the 1st floor where the clinic was, and we would use electronic data capture and other validated measures in our clinical training. And the idea that there was not more cross-pollination from the 3rd floor to the 1st floor was something that stuck with me when I came to Mac. And at the heart of this, the idea was that we're going to use the same data point to do triple the work. We're going to use the technologies of research to collect data that will be fed back to the patient and the clinician to inform their care. But by collecting it routinely over time, we're going to aggregate quality improvement data sets that will tell us about the nature of the patients in a given program. And then the same data set used for quality improvement at the program level can ultimately be used for research purposes to advance the field by doing more advanced data analysis to make broader inferences. So the idea is that we essentially use electronic data capture as a platform to achieve all 3 of these ends. The first end is in near real time because you're feeding the data right back to the patient and the clinician. The quality improvement is in the intermediate time scale. It's usually monthly, quarterly, or annually. Research takes longer, but it aggregates over time. So that's the DNA of this approach. And the other thing that's really critical to this is that we use electronic data capture to build in branching logic and other algorithms to do the heavy lifting of the scoring. So instead of just collecting the data, we then code it into this person screens positive or negative. This is how severe they are. And in some cases, we can add clinical flags that say, hey, pay attention to this. You might want to refer out to this service. So we can basically use that electronic data capture as an algorithmic clinical decision aid. We're not telling people what to do, but we're taking patient-reported outcomes using validated measures, feeding it back into the system to aid the clinician. So this is a good example. What I'm going to show you is now where we've implemented this so far. This is the project that has been supported by Health Canada over the last 3 years. Before that, it was supported internally by the Peterborough Centre for Addictions Research. We've now implemented measurement-based care for substance use disorders in a lot of different settings. It started out in concurrent disorders at MHAP West 5th and in our community settings. It's now in lots of different clinics at West 5th. And we've been really delighted to partner with the Firestone to try it in Terrence's clinic in order to see if it could be useful. A critical thing that I want to emphasize is it's not one size fits all. Every clinic has different needs. The Borderline clinic has additional measures that measure aspects of borderline personality disorder. In the Firestone implementation, we only focus on inhaled substance use. And you'll see in a couple of other things too. But every clinic, it's not a matter of top-down saying you have to measure all these things exactly the same way. It's saying you are almost certainly exposed to substance use in your clinic. How do you measure that and the other collateral features in a way that's useful for you. The other value of implementing this system in a lot of different settings is that it then means we can aggregate across these different settings into what's called a quality improvement data warehouse. So then we can say, what does depression look like in 9 different clinics? What does anxiety look like in 9 different clinics? How does the prevalence of head injury or tobacco use differ across clinics? So it really provides us a very powerful platform for aggregating data and making inferences. So let me show you what this looks like in terms of a standard mental health and addiction setting. So this is the feedback report that would go to a clinician based on the assessment in this case, the young adult substance use program. So the individual comes in for their intake, they complete a online assessment with branching logic, so it only assesses the things that are relevant to them. And what's generated for the clinician is a set of their demographics, a profile of their substance use, alcohol, cannabis, tobacco, other substances, the level of severity, their motivation for change using readiness rulers, how ready they are to change, how important change is, how confident they are in changing. We generate their psychiatric screens. We flag for self-harm. We also look at history of head injury. And so this is a hockey card or a baseball card that gives the clinician essentially a cheat sheet for what should I be thinking about before I go into my intake interview. And rather than starting with, how can I help you today? You start with, okay, I'm hypothesis testing from the start, and I have a set of priorities. So what does this look like in terms of the Firestone? This is what we've been trialing. It's an iterative process in which we continue to tinker and identify what's going to be useful. Because this is a lung health focus, we're focusing on tobacco use and relatively high resolution tobacco use. So past year and lifetime smoking, an aggregation of pack years, the number of quit attempts, and past strategies that people have used. We also look at their cannabis use, their frequency, whether they're using cannabis for recreational purposes, for medical purposes, or both. And we also look, if they do say that they're reporting cannabis for medical purposes, why are they using cannabis? There are many different reasons people use cannabis for medical purposes. And we really think that it's valuable to have that information. But then we are assessing a few other domains. We're assessing depression and anxiety and pain, common conditions that may suggest referrals to other services. And then most recently, we've added the McMaster Cough Severity Questionnaire that was developed by Imran Satya as a way of then getting a kind of broad spectrum indicator of cough severity in these patients. So this generally takes between 5 and 15 minutes for patients to take, and then provides the clinician with a report. This is what the Firestone report looks like. So this is what's automatically generated from the measurement-based care system. So you can see that there's demographics. This person was a 44-year-old woman. We have gender and sex differentiated, although just gender in the feedback report. It gives a profile of their tobacco use. So did they smoke in the last 12 months? Are they a current smoker? How many years have they smoked for? What's the average number of cigarettes per day? What's their total pack years? How much do they spend on tobacco each month? I find that clinically is actually a very important piece of feedback to give. How much they spend on tobacco annually. We also measure their readiness to change, their readiness, importance, and confidence. And what you can see highlighted in green here is something we've just recently added in response to a point that Terrence made. This is a flag that flags people who are ready to change at a 7 or higher. Actually, it's at a 6 or higher. So anyone who basically says, I'm ready to change my smoking, is now flagged to the clinician that they should be potentially encouraged to pursue a smoking cessation program. We also look at their quit attempts. Have they tried to quit before? How many times have they tried to quit before? And what's the longest they've been able to quit for? So what we're really trying to do is give a snapshot of the person's tobacco use. We also give a taxonomy of the different smoking cessation strategies. So have you tried gum? Have you tried patch? All the different nicotine replacement strategies. Have you tried a quit line? Have you tried e-cigarettes? Have you tried Chantix? Have you tried Zyban? RTMS we'll talk about a little bit later. But what we're really trying to do is, again, give a sense for what is the person's quit background. So if something has not worked before, let's not recommend it again. If they've tried every form of NRT, it's time for a prescription med probably. If they've tried every form of NRT and Zyban and Chantix, maybe they need an intervention for refractory patients like RTMS. There is a stepped care algorithm for escalating levels of intervention. This is the kind of data that we're hoping can contribute to nudging people either toward a cessation attempt or within that context toward a cessation attempt that's actually going to help them achieve recovery. We also do measure cannabis use. So the feedback report shows how often do they use cannabis? Are they using for medical purposes, recreational purposes? Do they have a medical authorization from a physician, or are they using medically but just purchasing from the recreational market, which is an extremely common pattern, the most common pattern among individuals who report medical cannabis use. The last piece of the puzzle is what about cough severity? So this is the McMaster Cough Severity Questionnaire. The feedback report now generates responses to all the different items. And what you can see is it doesn't give you a number, 1, 2, 3, 4, 5. It converts the numbers into the patient-reported outcome. So you can see never, several times, many times. So instead of having to interpret a score, what the clinician can do is actually see, okay, so these are the symptoms that are being endorsed, and there is a score in terms of percent maximum, because there isn't at this point an established severity range, but there's both a quantitative and a qualitative dimension to the questionnaire that's provided by the feedback report. The last piece of the puzzle is, are there any other mental health or somatic concerns? And that's where we use the PHQ-9, the GAD-7, and the DVPRS to measure anxiety, depression, and pain. And we flag whether a person is screening positive or negative for these conditions, which would suggest maybe referring to the ATRC, the Anxiety Treatment and Research Center, or the MTRC, the Mood Disorders Treatment and Research Center, in order to address comorbid mental health issues. So this is the current iteration of the Firestone report. It's only probably version 1.3. We will get to 1.7, we will get to 2.0. The point of the measurement-based care system is that it's continuously updated. So as clinicians have new needs, the most recent identified need is adding the COPD screen into the same assessment. We simply update it, and then the next iteration is created. And again, this is a clinical initiative. It's not a research initiative. We don't go to the REB and say, can we have permission? This is for clinical purposes. We move forward, and we have REB permission to do retrospective chart reviews to ultimately access retrospective data and use these data for research purposes also. All right, so let's move to what this looks like in terms of the QI and quality improvement component. So that's what a patient looks like. What about the program? So at the program level, this is what it looks like in terms of our mental health and addiction programs. This is the Womankind Withdrawal Management Program. This is a monthly report that gives a snapshot of these are the patients that were cared for over the last month. This is their alcohol severity, their drug use severity, the most common mental health comorbidities, the level of suicidality, whether there's gambling, head injury. This is a way for the program manager to get a snapshot of the clinical milieu and can be updated monthly, quarterly, annually. For the Firestone, I'm sorry, before I go on, in addition to these monthly reports, the value of continuous quality improvement is that this can generate publications to the larger field to advance what we know about the efficacy of our program. So this is just an example of a publication evaluating our young adult substance use program using that QI data that would typically be in a program report, and then analyzing it over time to focus on how effective this program was. This is a program that was funded by the Boris family to address an unmet need in terms of substance use issues in young people in Hamilton. And one of our priorities was showing our stakeholder whether or not our program was effective. So we used this QI data to then basically do a formal early stage evaluation. In this publication, the 3-year outcomes are currently under second review for a longer term outcome. But what this allowed us to do was to actually demonstrate, does the program reduce substance use? We see significant reductions in cannabis use, significant reductions in illicit drug use, significant reductions in alcohol use. Does it affect mental health positively? We see significant reductions in depression, significant reductions in anxiety. So we can leverage the quality improvement data to actually demonstrate that our interventions are working, and to also focus on patient-centered outcomes. So in this case, in this initial small cohort, we looked at quality of life, and we were able to demonstrate that over the various intakes, over the various check-ins following intake, we saw a significant increase in all domains of quality of life, about a 20% increase over the course of participating in the intervention. So these QI data are really valuable, not only for understanding the patients that you're serving, but also then contributing to demonstrating our outcomes and advocating for our treatment interventions by showing that they work using real-world data. So what does this look like for the Firestone? So this is the Firestone, either monthly or cumulative data report. So we've had 85 patients who've done the measurement-based care assessment before. And so there have been 85 of those individual patient reports, but this is a way of basically rolling up all those data into a profile of what the overall patient characteristics are for those 85 patients in the COPD clinic. So what you can see is a snapshot for whoever would be interested at the program level, in which we can see there's 85 people, 2/3 are female. The mean age was 68, but the range was 36 to 89. There were, in terms of smoking characteristics, about 80% reported a lifetime history of smoking, 60% reported past year smoking, and for patients who are at intake, 35% were active smokers. The thing that sort of stopped me in my tracks was that the mean years of smoking was 45.6 in this patient population. So 45 years of smoking, 36.88 pack years of smoking, and an average cigarettes per day among the smokers of 16, so approaching a pack a day. So what we see is that there's a very heavy history of tobacco use. That will come as a surprise to no one. Even still, there's a substantial portion, about 1/3, who are still active smokers, smoking around a pack a day. In addition, we see a large proportion of, a non-trivial portion, I shouldn't say a large proportion, a surprisingly high proportion of patients who are reporting cannabis use. So about 1 in 5 patients using cannabis, 10% using 4 or more times a week, which I found surprising. And the majority reporting medicinal cannabis use, 70% of the active cannabis users saying they're using it for medicinal purposes. I'm not sure what the standard practice is, but I'm going to guess that most people aren't asking a lot about medical cannabis use in these patients. And so this is a kind of flag for, could this be a prompt for a conversation? Are you using inhaled cannabis? Are you using edibles? Are you using an oil? When we look at the most common reasons, so this feedback report gives the top 4 reasons for medical cannabis use. The top 2 are mental health, depression and anxiety, 2 indications for which there's almost no evidence, by the way. And as a psychologist, I would recommend against cannabis for any mental health condition, as the Canadian Psychiatric Association recommends also. So the most common reasons tend to be the ones for which we actually have the least evidence. When it comes to chronic pain and sleeping, the 2nd, the 3rd, and 4th reasons, there's better evidence, arguably not particularly conclusive, but better evidence. So lots of room for clinical discussion based on the data that are coming out. The other thing that I find striking is that the good news is, in some ways, in terms of smoking cessation, people have tried to quit a number of times before. They've tried a lot of different strategies. Most of the first-line interventions, nicotine replacement, at least spray, inhaler, lozenge, or tablet, is endorsed by 60% of patients. That's good news. Below that, less than half of the former smokers or the active smokers have tried the other interventions. There's a laundry list of other evidence-based treatments that are not being used in these patients, at least in these first 85 patients. And what we see when we ask what percentage of them are willing to try something is that actually a large proportion do say, I'd like to try that, suggesting that if they were referred to an intensive smoking cessation treatment path, there might be, they may be able to achieve success. So what we see is that in the Firestone, we have been able to create a clinician feedback report that hopefully touches on the high points of tobacco use and cannabis use. And we do now have a quality improvement program report. We haven't started doing research using these data yet. This is really going to be at the direction of the clinicians who are collecting these data, because these data are patient data. They live in Dovetail. They are accessible via our system, or accessible to anyone who's collecting them. They're clinical data. They're not research data. But I do want to illustrate that we can do clinical research, and that we do have a number of different REB projects, REB approved projects, that are using this existing measurement-based care data. So just to give you a quick example, when we look at tobacco use in our addictions programs, this is a paper that is in press currently at Nicotine and Tobacco Research, looking at the prevalence and features of tobacco use in our addiction programs. And the overall prevalence of tobacco use in Canada now is around 11%, which is actually pretty good globally. In each of those 5 programs, the prevalence ranges from 62% to 82%. So our addiction patients smoke 6 to 8 times more than the general population. And as I alluded to before, they smoke more cigarettes, they smoke typically at higher levels, and they're also consuming other inhaled drugs like cannabis, like cocaine. And so it's a very high-risk population from a lung health standpoint. Just to put this in context, these are the same data, but it shows the cigarettes per day on the far right. So just in terms of cigarettes per day, across the 5 services, the lowest number is in the young adults, smoking about a half pack a day. In the men's program, MASH, Men's Addiction Services Hamilton, they're smoking around a pack a day, 18 cigarettes a day on average. So this is a way that we are documenting the nature of tobacco use in our other addictions programs. What's really interesting is we looked at their motivation for change using the readiness ruler that I alluded to before. And on average, the readiness to change was a 5. So this is a distribution of all the 1,200 patients. The individual data points are below the average, and the distribution is on the top. And what you can see is that even though the average suggests that they're pretty ambivalent, the data are truly trimodal, right? There's a group that is right in the middle of the readiness ruler. I'm not sure if I want to change. There's a group that says, there's no way I'm changing now. I've got bigger fish to fry. I'm in withdrawal management again. I'm not quitting smoking today. And there's another group, the largest group, rated themselves 9 and 10 in terms of readiness to change, suggesting that they actually are ready to make a change now. And what we know from an evidence standpoint is that people who try to quit smoking in the context of other addiction treatment are as successful or more than people in the general community. So this suggests, exactly to your point raised before, how does these data speak to research questions? It suggests that we need to have an intervention that speaks to each of these different domains. We need to have something for people who are ready to change, something that moves people from being ambivalent to being ready, and harm reduction strategies for people who are not ready to change now to reduce the harms of tobacco. And what we were also able to do in this study, and I'm not going to dive deep into these data, but we can also then take the data and use whether it be correlations or regression or machine learning to analyze the different patterns. You can see a heat map of different patterns with tobacco use and other comorbidities on the left. You can see how on the right, how we found those different patterns of motivation mapped onto alcohol use, to other drug use, to impulsivity as measured by a delay of gratification. So once you have the data, there's all sorts of things you can do from a research standpoint, and measurement-based care becomes your vehicle for collecting data in a systematic, valid way from a clinical setting to do so. So just to kind of come full circle, this is the vision of the measurement-based care system, that we make the same data do triple the work. We make it help the clinician and the patient. We make it help the program from a QI standpoint, and we make it contribute to the field via clinical research, all using the electronic data capture platform and back-end algorithms to process the data. And ultimately, the hope is that if we can roll this out, as we're trying to do now across the entire mental health and addiction program and other medical programs at St. Joe's, we really create these learning health systems where there are ever-growing, ever-aggregating data sets that produce practice-based evidence that then generates the next generation of interventions, and in turn improves ultimately patient outcomes. So I'm running a little short on time. I have, as usual, slightly underestimated my timing. So I'm going to move pretty quickly through the last segment. But this is moving from sort of observational or data collection using the measurement-based care initiative to new treatments that could be relevant to respiratory patients that you may not be familiar with. So one of the things that we're really focusing on in the Peter Boris Center is neuromodulation as a novel strategy in psychiatry. And most people here probably know that the treatment of mental illness has been historically either using psychotherapy or pharmacotherapy. But direct electrical stimulation of the brain in selected regions that are implicated has really emerged over the last decade as a very promising strategy. And this ranges from very low invasive strategies like TDCS, which are basically applying a weak electrical current to the scalp, to medium invasive strategies like RTMS and deep RTMS, to quite invasive strategies like deep brain stimulation, which requires neurosurgery. And we've pursued all three of these domains. The DBS work is happening with neurosurgical collaborators in Toronto. But at the Peter Boris Center, our real focus has been on deep repetitive transcranial magnetic stimulation, which is using high-powered magnets to stimulate specific regions of the brain and actually specifically networks that are implicated in different conditions. And we use a system that was created by a company called Brainsway in Israel and has received FDA and Health Canada approval for several different indications using these helmets that contain the magnetic coils that stimulate the brain according to the specific network. So the H1 coil is approved for depression. That focuses on the medial prefrontal cortex. The H4 coil is focused on the insula and lateral prefrontal cortex. That's the one that we'll talk more about for tobacco use disorder. And the H7 is approved for OCD. That focuses on the anterior cingulate. We're one of the few academic health sciences centers in Canada that has all three coils, and we're actively using them in ongoing trials at present. What I'm going to highlight is really how strong the evidence is in terms of tobacco use disorder and potentially cannabis use disorder, because this is really the state of the evidence in terms of refractory tobacco use disorder. This is the pivotal clinical trial that resulted in the Health Canada and FDA approval of the H4 coil for the treatment of smoking cessation. This is not a small intervention. It is 20 days of sessions, basically a month of treatment. It involves coming to the center every day. We actually find that that's beneficial for patients, but it's not a light touch by any means. But the data are very strong. These are the data that led to the FDA and Health Canada approval. So in the intent to treat or the completer samples, which you can see ITT and CO, you can see that the active stimulation compared to the sham stimulation significantly improved the continuous quit rate at 6 weeks and at 18 weeks. And if we dive more deeply into the data and look in terms of tobacco use and craving week after week, the active treatment compared to control shows significant differences basically at every week relative to baseline. So this has been shown to be really quite effective for tobacco use disorder. We literally yesterday just finished our last participants for our cannabis use disorder pilot trial. These are actually our staff. You can see Carly, Allen, and Shelby practicing in our deep TMS lab, focusing on the H4 coil. And what you can see on the right is the reduction in cannabis use across our trial over time in the first 7 patients. We've just finished through patient 12. These were data from an earlier presentation. So we see a significant overall reduction. But most dramatically, if you look at baseline grams per day and standardized THC units per day, we see a 90% reduction and an 86% reduction overall. This is an open label feasibility trial to set the stage for a sham-controlled RCT, but we're seeing extremely positive results. I'm one of the clinicians on the trial as a psychologist, and so the patients that I've seen have been, in some cases, miraculously able to manage very severe withdrawal and very significant challenges in terms of cravings via this approach. So we're seeing really very positive outcomes. looking at secondary outcomes like cravings and the reinforcing value of cannabis, we're seeing very dramatic reductions in cravings. We're seeing the value of cannabis as one of our experimental assays really dropping through the floor over the course of the 20 sessions. So we're essentially seeing very positive results. I'm going to wrap up here. I hope my evangelizing has landed in a positive way, because I just feel like there's incredible potential here and really positive momentum already. I think that to me, if we can sustain and expand measurement-based care for substance use in respiratory health settings, that would be a really powerful way to merge these two areas together and improve not only quality, but research in the field. I do think that there's tremendous possibility for impact in terms of randomized controlled trials of novel interventions for patients with respiratory illness who have been refractory when it comes to smoking cessation or cannabis use disorder. And I hope that our lung lab at West 5th can provide some physical infrastructure for whether it be satellite clinics or opportunities to manage the lung health of some of our mental health patients who unfortunately either are already suffering from lung disease or are at very high risk of experiencing lung disease in the future. So I'm going to wrap up here. The last thing I will say is for anyone who has patients who are using cannabis for medical purposes, especially seniors, we do have a cannabis knowledge translation initiative, including a public-facing cannabis in older adults series called Canoa that could be very useful. So anyone who is, any seniors who are using cannabis for medical purposes could benefit from this. These are available at budtalks.ca. It's funded by the DeGroote Center for Medicinal Cannabis Research. We also have a module on cannabis use disorder, but I hope these resources will be useful. Ending with a slide that says discussion at 9:59 feels like a fairly disingenuous thing to do, but if we have any time to talk, I'd be happy to. And I'm happy to also stay after if anyone's available and wants to chat. Thank you very much.
That was fantastic. I think, if you'll accept the offer, you mentioned that you might be willing to come back to talk to us a bit about cannabis. Maybe if the next academic year, we can bring you back because I really enjoyed that. I'd love to have a lot of time for questions. We only have limited time for questions.
I'm curious about these, magnetic stimulation. Like, that's really interesting. But what's the right patient? Because obviously, a lot of my patients who struggle to quit, it's a motivation issue, and obviously, if they're not motivated to quit, they're not motivated to come in for a month. So, like, how do you identify the patient who is trying to quit, struggling? Like, what is that phenotype look like that is going to go and do this and get that?
That's where I find the readiness rulers are really useful to just give me some sort of a quantitative metric for whether a person's ready to change and whether they're ready to commit to something that's as high touch as that. So for the trial, for example, we'll use a minimum threshold of at least 7 out of 10 to be eligible for the trial. Clinically, for a person who is more ambivalent, that's where motivational interviewing can be incredibly helpful to really sort of either move them forward so they're ready for something, and maybe it's not RTMS, maybe it's just NRT, dual formulation NRT, maybe it's Chantix, but if they're not, MI can also disambiguate whether maybe they need harm reduction. And I think harm reduction has been sort of a dirty word in tobacco use disorder for a long time, but especially in patients who are quite ill with lung disease, if you can reduce simply the expired carbon monoxide, if you can reduce the cigarettes per day, or if you can migrate to non-inhaled products or non-combustible products, that's the other direction to go. So for someone who's in that more kind of, just to give it a number, that 4, 5, 6 range, that to me is a patient who you can kind of, motivational interviewing would be really useful to say either how do we move them forward or how do we, implement harm reduction.
With the cannabis use disorder using the coils, seems like you jumped right to sort of the most extreme intervention for trying to get them off cannabis. What other cessation tools are there to prevent people from using cannabis excessively? And are those not effective at all and you need to go to the deep end?
It's not a matter of them not being effective at all. We actually have a CIHR grant to do a clinical guideline on evidence-based treatments for cannabis use disorder. There are no approved medications. So unlike alcohol or tobacco or even opioids, there are no medication options. The options that have been shown to work essentially now tend to be psychological treatments, especially motivational interviewing and cognitive behavioral therapy. They're moderately successful. They are very resource intensive. Most people won't have access to them. And the reality is many people are refractory. So for what we're really trying to do is build out the kind of the spectrum of interventions, because for folks who are lower severity, screening and brief intervention may be helpful. The more protracted MI plus CBT could be helpful. This is intended for people who are generally refractory or have not responded. But the other reality is we see people who are using Herculean amounts of cannabis now. So it's not unusual for me to talk to a patient who is using 6 grams a day of 30%, and then they're crumbling shatter into that at 90%, and or using a 90% vape 40 times a day. So the level of severity of addiction to cannabis that I see now is radically different from what I would have seen when I trained 20 years ago. And so we really need something that's different. The other reality is abstinence is almost always off the table because people are very severely physically addicted. And so we usually have to do a tapering or an initial harm reduction, not harm reduction, but a graduated progression towards abstinence within that program too, just because it's not, cannabis is different nowadays, and the manifestations of cannabis use disorder are very different too.
So I actually had a question. You had mentioned that you have added the collection of the cost of smoking, the monetary cost of smoking to the questionnaire, and obviously there's a lot of research that paying people is one of the best ways to get them to quit smoking. Yeah. Is this going to lead, you think, to interventions like verbal or psychosocial interventions that focus on cost and helping people modify people's behavior that way?
I would love to see more of that. Contingency management is one of the best supported treatments, and it's been a mystery to me why we haven't been able to implement it especially in environments like the public health sector in Ontario. In that cannabis trial, we actually used contingency management to incentivize people to come to all 5 of their sessions for a week. If I had my druthers and I could have the kind of high intensity smoking cessation program, I would absolutely include those incentives, because even though they don't typically add up to a large amount of absolute dollars, what they do is they just give you one more tool to motivate people to come to the visit, try to get their CO lower. And it's just, there's no silver bullet, but it's part of the kind of blunderbuss of strategies that we can use to maximally help people quit.
Fantastic. So one last question.
This would be a quick one.
Yeah.
What kind of adverse effects are associated with TMS?
Yeah, great question. So one of the contraindications is history of migraine or chronic headache. Headache is not uncommon. We treat it with NSAIDs, and it typically remits fairly soon after the session. There can be a little site pain. People's teeth chatter during the sessions, and they can experience some. I mean, it's a powerful electromagnetic current that's being sent into the brain. So that can cause a little bit of discomfort, some eye twitching. The most severe adverse event is seizure, but that has a risk that's lower than 1 per 10,000 patients. So we've never seen anything like that, but it is something to be aware of. So a history of seizure disorders would also be contraindicated.
Fantastic. I really enjoyed the talk. I look forward to hearing from you again next year, hopefully. Great. Thank you.
Thanks so much for having me. This is great.
I enjoyed that. That was good.